Hello friends, this is a continuation of yesterday's video, and today's video let's see how we manage this tough curved canal. So after the initial access and orifice shaping, the most important aspect is the establishment of glide path, which can be done with manual files, but my choice is always a direct rotary glide path, and in this case I'm using 15.5% from Walden S, and we use it along with an integrated endomotor. Here I'm using Coltein's integrated endomotor. You can see that this file 15.5% is a martensite phase file, and hence in spite of being 15.5%, it's a very good file for glide path, and it's more predictable, as personally I feel martensite phase files which are lesser in taper are more prone to fracture. So the canal is pretty tough and I was not able to reach the length in one go. So you can see me stopping, irrigating and then going ahead, and now the moment I reach the apex, you can see the file slowing down, auto reversing, and that's how we predictably shape the canal exactly to the biological working length. And the same process is repeated for all the canals. And in this case it was also difficult to instrument. It's a left mandibular molar. You can see me holding the endomotor in my left hand, which I frequently do when I work in the third quadrant, which gives a much more straight path for the canal when you're working from a 12 o'clock position. So the irrigation that we are doing in between each rotary file is with the help of continuous ultrasonic irrigation. I have dedicated scaler with a tank and connected to U files. So you can see now almost all the canals glide path is established. And now the next most favorite file for me for preparing these extremely narrow and curved canals is 25% from Highflex EDM. It's a complete martensite phase files. And once the glide path is established, the preparation file will reach the length pretty easily. You can see the file slowing down as I near the apex, and once we reach the biological working length, the endomotor automatically stops. And here you can see the continuous irrigation coming from the scaler tank. It allows more volume to be deposited. You can just use saline in the scaler. I prefer to use a mild irrigant, mild hypo with little bit of chelator, like continuous chelation. And the role of continuous irrigation is just to flush out the debris, and then we do gentle irrigation with full strength hypo also. This is full concentration sodium hypochlorite, but you can see how carefully we use the motion, up down motion with safe ended needles, and you can see the suction tip right at the orifice, at the pulp chamber level, not allowing anything to extrude. So the last file that we have used to prepare is a 25%, considering the canal curvature and length. You could see the master cone, and in this particular radiograph we call it as a bullseye effect. When you have root canal curvatures towards the lingual side, will not be able to see radiographic apex pretty clearly. And now we again irrigate and agitate. In curved canals, stiff ultrasonic tips may not be able to reach the apex, so we prefer using flexible air sonic tips. Again, is my favorite. And we already spoken about this. This is a do-it-yourself suction tip, because it's equally important to evacuate the old irrigant from the canal before depositing fresh irrigants. So now the canal is almost dry, and most of the time we may require just one paper point when you do endo suction. And again, considering the complexity of the case, we prefer a sealer with good flow. So Cerasil from Metabiomed is used here. Just a single cone obturation, and as I have shown in some of my previous video, you can just use statics to condense the GP. It also allows some ultrasonic flow of sealant into some ramifications. And bioceramic sealers are one of the easiest to clean, and as always we seal the pulp chamber immediately after completing endo and removal of the rubber dam. So here I'm using SDR from Dentsply to seal the orifices, and this is the final post-operative radiograph handled with no manual K files. And looking at these are radiographs, these are cases where 2D radiographs may be sometimes misleading. So the role of apex locator is very important to identify the biological apex. You can also prefer to use a manual K file and an apex locator, but what we did here is direct rotary glide path with integrated endomotors, and we trusted the endomotor for the working length. And just out of curiosity, because radiographically we may feel these cases are little short of apex, but that's where it has to end, because we are trusting the apex locator that's inbuilt. We could see the dilaceration of the root. You can see the mesial roots dilacerating and almost coming closer to the distal root and also curving lingually. It's the mesial root. You can see it now almost when you are going towards the distal section, and that's causing, this is the curvature, the lingual curvature is what is causing your bullseye effect on your 2D radiograph. And always call my patient after 2 weeks. That's my first follow-up, and this is the 2 weeks follow-up, and then following this we will have 3 months or 6 months follow-up radiograph. Hope this video was useful. See you all soon in our next video.